Welcome to the Pediatric Pharmacy Association Core Competency Module on Pediatric Sodium Disorders. My name is Ellen Bickle, and I am the current Pediatric ICU Clinical Pharmacy Specialist at the University of New Mexico Hospitals. This presentation will review pediatric sodium disorders, including syndrome of inappropriate antidiuretic hormone, cerebral salt wasting, and diabetes insipidus. I have no conflicts of interest to disclose for this presentation. The objectives for this presentation are to define sodium and water regulation in the kidneys, identify sodium disorders based on laboratory and clinical findings, and indicate appropriate treatment modalities for the different sodium disorders. Here is an outline of the presentation. We will first start by reviewing sodium and water regulation by the body. Then we'll discuss different hyponatremia disorders, including cerebral salt wasting and syndrome of inappropriate antidiuretic hormone. And then we'll finish with hypernatremia disorders, including diabetes insipidus. Here are the majority of the abbreviations that will be utilized throughout this presentation. Any additional abbreviations that may be particular to a specific slide will be included on that slide. Antidiuretic hormone is also known as arginine vasopressin, and it is responsible for regulating the body's retention of water. ADH is a peptide formed in the hypothalamus that is transported to the posterior pituitary, where it is released into the blood. ADH has two principal sites of action, the kidney and the blood vessels. The primary function of ADH in the body is to regulate extracellular fluid volume by regulating the renal handling of water. ADH acts on renal collecting ducts via vasopressin 2 receptors to increase water permeability, which leads to decreased urine formation, hence antidiuretic hormone. A secondary function of ADH is vasoconstriction through binding to the vasopressin 1 receptors on vascular smooth muscle. The release of ADH is controlled by several factors, including changes in osmotic pressure, changes in volume status, exercise, angiotensin II, and emotional stress. Hypovolemia results in a decrease in atrial pressure. Baroreceptors decrease their firing rate when there is a fall in atrial pressure. This triggers the posterior pituitary to release ADH with a goal to increase atrial pressure and blood volume through increased water reabsorption and decreased urine formation. Hypothalamic osmoreceptors sense extracellular osmolarity and stimulate ADH release when osmolarity rises, which can occur in dehydration. Angiotensin II receptors located in the hypothalamus help to regulate ADH release. Increases in angiotensin II stimulate ADH release. Blood volume is determined by the amount of water and sodium ingested, excreted by the kidneys into the urine, and lost through the GI tract, lungs, and skin. To maintain blood volume within a normal range, the kidneys regulate the amount of water and sodium lost into the urine. Blood is filtered at the glomerulus, and this filtrate contains sodium, water, and other waste substances. As this filtrate travels through the proximal tubule, thick ascending loop of Henle, distal and collecting tubules, sodium transport is maintained by angiotensin II, leading to sodium retention. In the collecting tubules, aldosterone stimulates sodium retention. This retention of sodium leads to increased water reabsorption into the body. Another hormone, ADH, helps to increase water permeability in the late distal tubule and collecting tubules, allowing water to be reabsorbed and reducing urine volume and water loss. Osmolality is the total concentration of solutes in water. Plasma osmolality is maintained by strict regulation of the antidiuretic hormone system and our thirst. As plasma osmolality increases, there is increased secretion of ADH by the posterior pituitary, which leads to water reabsorption by the kidneys with the goal to decrease our plasma osmolality. However, as our plasma osmolality decreases, there is decreased secretion of ADH, which leads to decreased water reabsorption and increased urine formation or diuresis. And now we're going to shift gears and discuss hyponatremia. Hyponatremia can be defined based on severity and duration. Sodium levels may vary by measurement technique. Normal values are 135 to 145 milliequivalents per liter and are based on measurements from automated blood biochemistry autoanalyzers with ion-selective electrodes using indirect potentiometry. Whole blood sodium measurements obtained via point of care tend to be 2 to 3 milliequivalents lower than central-based measurements. After identifying hyponatremia, a detailed H&P should be performed evaluating for recent changes in fluid intake, salt intake, urine output, or other fluid losses, including diarrhea and vomiting, and reviewing for other signs and symptoms that may be related, including edema and ascites. Oftentimes, patients with mild or moderate hyponatremia may not experience any signs or symptoms until they progress to severe hyponatremia. For patients with severe hyponatremia or those experiencing a rapid decrease in their serum sodium in an acute time period, it is important to promptly correct their sodium to avoid cerebral edema, irreversible neurologic damage, respiratory arrest, brainstem herniation, or even death. Treatment for severe hyponatremia with severe symptoms could rely on hypertonic saline boluses of 3 to 5 mL per kilo administered over 15 minutes. This may be followed by an infusion of 3% saline or normal saline, depending on the severity. For patients with concurrent hyponatremia and hypervolemia, loop diuretics could be considered to facilitate increased water excretion. Please refer to the Fluids and Electrolytes presentation for more general information on management of hyponatremia. It is very important to avoid rapid overcorrection when treating patients with hyponatremia, as this can lead to osmotic demyelination syndrome. In chronic hyponatremia lasting more than 48 hours in duration, cerebral adaptation is likely to occur. Hyponatremia induces an increase in the intracellular fluid and interstitial fluid. During adaptation, the water moves from the interstitial compartment to the systemic circulation within minutes to a few hours. During the following hours, the depletion of intracellular electrolytes and non-electrolyte osmolytes is responsible for the movement of water from the intracellular space into the extracellular space and then later into systemic circulation, leading to decreased brain water content, thus cerebral adaptation. Due to cerebral adaptation, we see a decreased risk of the severe symptoms often associated with hyponatremia, including cerebral edema. However, also because of this adaptation, correction should occur at a slower rate to avoid fluid shifting from the brain into the body, leading to osmotic demyelination. For those patients with acute and severe symptoms, meaning less than 48 hours in duration, severe symptoms are more likely to occur, and they typically tolerate a more rapid correction of their sodium with hypertonic saline due to the unlikely cerebral adaptation occurring. For chronic hyponatremia, a rate of correction should be 4 to 8 milliequivalents per liter per 24 hours, whereas patients with acute hyponatremia can have a correction of 6 to 12 milliequivalents per liter in 24 hours. When evaluating hyponatremia, we must also evaluate the serum osmolality to help determine the underlying cause and treatment options available. Patients with low osmolality are considered to have hypotonic hyponatremia, and we then further assess their volume status as either hypovolemic, euvolemic, or hypervolemic. Patients with normal osmolality are considered to have isotonic hyponatremia, and we should then further assess for hyperproteinemia or hyperlipidemia to evaluate for pseudo-hyponatremia, where the patient's serum sodium is actually normal, however there are markers in the blood affecting the serum sodium reading. Patients with high osmolality are considered to have hypertonic hyponatremia, and we should assess for hyperglycemia as well as recent mannitol or contrast use, which may be leading to false readings of their serum sodium. In cases of hyperglycemia, a corrected sodium should be calculated prior to providing any sodium for sodium correction. For patients with hypovolemic, hypotonic hyponatremia, a urine sodium can be evaluated to determine the underlying cause as either renal or extrarenal losses of sodium. Euvolemic hypotonic hyponatremia, a urine osmolality can be assessed to determine the underlying cause. In cases of elevated urine osmolality, the underlying cause may be secondary to SIADH, hypothyroidism, or adrenal insufficiency. In cases of low urine osmolality, the underlying cause may be due to primary polydipsia or low solute intake. And for patients with hypervolemic hypotonic hyponatremia, a urine sodium can be evaluated to determine again if the underlying cause is primarily renal, such as renal failure, or extrarenal, including heart failure, cirrhosis, and hypoalbuminemia, leading to fluid overload. The first disease state we're going to talk about is going to fall under hypovolemic hypotonic hyponatremia. Cerebral salt wasting, or cerebral salt wasting syndrome, is a form of hypovolemic hypotonic hyponatremia secondary to extrarenal losses of sodium. Cerebral salt wasting is a syndrome characterized by inappropriate renal sodium wasting in patients with CNS disorders. Cerebral salt wasting is most commonly reported in patients with subarachnoid hemorrhages, followed by traumatic brain injuries, anoxic brain injuries, brain tumors, infections, and status epilepticus. Though the incidence is not well defined and is likely underreported, some reports state that cerebral salt wasting may account for fewer cases of hyponatremia than SIADH. The risk factors are also not well defined. In a retrospective review, authors aim to determine risk factors associated with cerebral salt wasting and SIADH among children undergoing surgery for intracranial tumors. This study included children 0 to 19 years who underwent a first intracranial tumor surgery with post-op hyponatremia defined as sodium less than 130 milliequivalents per liter. They differentiated cerebral salt wasting from SIADH by urine output and fluid balance. 39 hyponatremic patients were evaluated. 17 had cerebral salt wasting and 10 had SIADH. Cerebral salt wasting increased natriuresis compared to those with SIADH, with a mean urine sodium of 211 compared to 28. Age less than 7 years and female sex were significant risk factors for cerebral salt wasting, with p-values of 0.03 and 0.04 respectively. Those with cerebral salt wasting had a trend towards increased sodium variability and symptomatic hyponatremia. Most reports of cerebral salt wasting state that this syndrome occurs within 10 days of neurosurgical procedure or event and is often transient in nature. The mechanism by which cerebral disease may lead to renal salt wasting is poorly understood. There are two possibilities, including disruption of neural input to the kidney, leading to decreased sympathetic outflow, as well as increases in circulating natriuretic peptides. The sympathetic nervous system promotes sodium, uric acid, and water reabsorption in the proximal tubule, as well as renin release. Impaired sympathetic neural input could lead to reductions in proximal sodium and urate reabsorption, as well as impaired release of renin and aldosterone. Failure of serum aldosterone to rise in response to volume depletion would explain the absence of potassium wasting despite the increase in distal sodium delivery. Increased circulating natriuretic peptide is seen in patients with brain injuries, and these peptides impair renal tubular sodium reabsorption. Primary candidate is brain natriuretic peptide, or BNP, which decreases sodium reabsorption and inhibits renin release. BNP may also decrease autonomic outflow via effects at the level of the brainstem. In a case control study of 60 patients, 10 patients with a subarachnoid hemorrhage were compared to a control group of 10 patients that underwent craniotomy for resection of cerebral tumors and 40 control patients. Patients with subarachnoid hemorrhages had increases in urine volume and sodium excretion that correlated with a marked increase in mean plasma BNP, 15.1 versus 1.6 in the two other groups, as well as increases in ICP. Concentration of ANP was normal, while that of aldosterone was reduced. Speculation that renal salt wasting and the resultant volume depletion is a protective measure limiting extreme rises in ICP. In addition, the vasodilatory properties of BNP might decrease the tendency for vasospasm in subarachnoid hemorrhage. Renal salt wasting leads to volume depletion or hypovolemia, which provides baroreceptor stimulus for the release of ADH, thereby impairing the ability of the kidney to produce dilute urine and therefore leading to hyponatremia. Cerebral salt wasting is a diagnosis of exclusion based on clinical signs and symptoms. However, it should be considered in any patient with a CNS disease and hyponatremia. Cerebral salt wasting leads to decreased serum sodium as well as decreased serum osmolality, increased urine sodium and urine osmolality, as well as increased or possibly normal urine output, and evidence of hypovolemia. Some reports state that cerebral salt wasting can also lead to low serum uric acid. If you are unable to determine if a patient is hypovolemic, volume repletion could be considered. Volume repletion should lead to dilute urine. Removal of the hypovolemic stimulus should lead to antidiuretic hormone release, and excretion of dilute urine should lead to correction of hyponatremia. The differential diagnosis for cerebral salt wasting should include SIADH, which will be reviewed in depth, different hormonal imbalances, including glucocorticoid deficiency, which leads to increased vasopressin release, hypoaldosteronism, adrenal insufficiency, which can lead to hyponatremia with hyperkalemia, as well as thiazide diuretic use. Some argue the distinction between cerebral salt wasting and SIADH is crucial prior to treatment. However, others argue the distinction is less important, since all hyponatremic patients that have symptoms will likely be treated the same way. Theoretically, evaluation of the response to isotonic saline would help to distinguish between the two. Restoration of euvolemia and cerebral salt wasting should remove the stimulus to ADH release, resulting in dilute urine and correction of hyponatremia. But this has not been well documented in cerebral salt wasting. A lack of urinary dilution does not preclude cerebral salt wasting, since it might be expected that patients with subarachnoid hemorrhage could also have risk factors for SIADH. By contrast, isotonic saline often worsens hyponatremia and SIADH. As you can see, cerebral salt wasting and SIADH are very similar in regards to what's happening in the body in terms of sodium and osmolality. They both lead to decreased sodium and serum osmolality, as well as increases in urine sodium and osmolality. However, the big differences can be seen when looking at urine output and fluid status. In patients with cerebral salt wasting, we're likely to see normal or increases in urine output, leading to decreased fluid status or hypovolemia, whereas patients with SIADH often have normal or decreased urine output, as well as normal or increased fluid status. Because cerebral salt wasting is a diagnosis of exclusion based on clinical criteria, some authors have argued cerebral salt wasting does not exist. These authors argue that those given a diagnosis of cerebral salt wasting may be excreting excess sodium physiologically due to reduced venous capacitance caused by catecholamine-induced vasoconstriction, followed by volume expansion with sodium-containing IV fluids. The patient must not have a condition causing a deficiency of a physiologic stimulator of renal sodium reabsorption, such as aldosterone, or the presence of a natriuretic agent that is not directly related to cerebral lesion, including diuretics. Though cerebral salt wasting tends to be transient in nature and often resolves within 3 to 4 weeks, initial management is required. However, long-term management is typically unnecessary. It's important to avoid fluid restriction in these patients because these patients are often hypovolemic in nature. In those with a subarachnoid hemorrhage, fluid restriction may increase the risk of cerebral infarction and lead to worsened volume depletion and hypotension. We can replace volume and achieve euvolemia with isotonic saline. Once we've achieved euvolemia, we can continue to provide sodium supplementation either with hypertonic saline, IV in patients that are symptomatic and hyponatremic, with sodium chloride supplementation intrally, or possibly with fluticasone. Once euvolemia is achieved, sodium supplementation to maintain normal serum sodium levels should be considered. Hypertonic saline can be considered in patients with severe hyponatremia, in cases where hyponatremia can lead to detrimental effects to the underlying condition, such as traumatic brain injury, or in patients unable to take enteral sodium supplementation at that time. Hypertonic saline can be dosed as 3 to 5 mL per kilo as an IV bolus during times of symptomatic hyponatremia, followed by a continuous IV infusion of 0.5 to 2 mLs per kilo per hour, adjusted to maintain normal serum sodium levels, or whatever sodium is the goal for that patient. Enteral sodium supplementation should be considered in patients able to tolerate enteral medications to maintain normonatremia. Sodium chloride is available as 1 gram tablets as well as an oral solution of 4 milliequivalents per ml, which allows for easier dose manipulation. Sodium chloride supplementation may lead to GI side effects, including nausea, vomiting, and diarrhea. However, if administered along with feeds, the risk of these side effects is decreased compared to administration on an empty stomach. Due to the transient nature of cerebral salt wasting, patients often do not require long-term treatment with medications. Sodium levels should be monitored routinely when initiating sodium supplementation, but may be decreased once sodium levels normalize. Close monitoring of urine output and continued evaluation of sodium levels should be considered based on the patient's clinical status and in discussion with the team. We often initially monitor Q6 hours, followed by every 12 hours, eventually every 24 hours, and then that can be further spaced depending on that patient's clinical status. Sodium supplementation can be decreased and eventually discontinued based on the patient's sodium levels. If the patient's sodium levels start to rise, sodium supplementation should be decreased and further discontinued once their disease state has normalized. Cerebral salt wasting may lead to a mineralocorticoid deficiency via abnormally high circulating natriuretic peptides, leading to reduced steroidogenesis. Due to this pathophysiology, supplementation with fludrocortisone could be considered. Fludrocortisone is a potent mineralocorticoid which leads to increased reabsorption of sodium and loss of potassium in the renal distal tubules. The dose reported in literature is 0.05 to 0.4 milligrams per kilogram per day, divided in 1 to 2 doses. Due to the wide dosing range reported, consider starting at the lowest starting dose of 0.05 to 0.1 milligrams per kilogram per day, divided 1 to 2 times daily, and titrate to effect. Fludrocortisone is only available as 0.1 milligram tablets. However, these can be divided and crushed for administration, but this may lead to difficulties in administration to our small pediatric patients. Serum sodium levels should be monitored for dose adjustments, and the duration of treatment will be dependent on the duration of cerebral salt wasting in that patient. Literature often reported durations of 4 to 125 days of treatment. Now let's shift gears to talk about syndrome of inappropriate antidiuretic hormone, or SIADH. If you think back to this table that we discussed towards the beginning of the presentation, we'll now review patients that have euvolemic hypotonic hyponatremia. We will assess the urine osmolality, and if the patient has an elevated urine osmolality of greater than 100 milliosmoles per kilo, we could consider the diagnosis of SIADH. In SIADH, there is an inability to suppress secretion of ADH, which leads to excessive free water retention, leading to hyponatremia. This is the most common cause of pediatric hyponatremia. The incidence is not well defined and is likely underreported. There are a lot of conditions that our pediatric patients are prone to that have associations with SIADH. Pulmonary conditions such as pneumonia, bronchiolitis, asthma, cystic fibrosis, and positive pressure intubation, certain neurologic conditions including meningitis or encephalitis, tumors, trauma, hydrocephalus, and brain abscesses, endocrine disorders including hypothyroidism and cortisol deficiency, malignancies, as well as medications. There are many medications that can induce SIADH. Certain neurologic medications, including anticonvulsants, narcotics, and NSAIDs, many chemotherapy agents, including platinum compounds, vinca alkaloids, and ifosfamide, psychiatric medications, including antidepressants and antipsychotics, as well as many miscellaneous medications, including amiodarone, vasopressin, nicotine, monoclonal antibodies, and antibiotics such as linezolid and ciprofloxacin. There are 5 main patterns of ADH secretion that can lead to an SIADH-like picture. Type A is a grossly elevated level of antidiuretic hormone that is unresponsive to osmotic deviations. High hormone levels above physiologic range suggest ectopic secretion of antidiuretic hormone, most commonly by bronchogenic carcinoma. Type B is an abnormally low osmotic threshold for antidiuretic hormone release. This threshold is below that level of plasma osmolality at which plasma antidiuretic hormone becomes detectable in normal individuals. Type C is where antidiuretic hormone levels that are persistently in the physiologic range are neither suppressed by a low plasma osmolality nor stimulated by a rising plasma osmolality, and this may occur in patients with ectopic ADH secretion. Type D, normal osmoregulation, but urine is concentrated even if ADH release is suppressed. This can be due to a germ cell mutation in which vasopressin 2 receptor is constitutively activated, leading to production of ADH compound other than immunoreactive arginine vasopressin and a post-receptor defect in trafficking of aquaporin 2 water channels. This is also known as hereditary SIADH. In type E is where there's altered baroreceptor signaling of ADH in response to blood pressure or blood volume. First-line treatment in managing SIADH is fluid restriction, as well as identification and correction of underlying conditions when possible. There's no clear guideline regarding the amount of fluid restriction. However, most references recommend starting at 75 to 80% of the patient's maintenance fluids and titrating as needed and tolerated. If fluid restriction is inappropriate or ineffective, you could consider the addition of loop diuretics with sodium supplementation. If patients develop symptomatic hyponatremia, hypertonic saline boluses with or without infusions should be considered. Third-line treatment options include urea supplementation and vasopressin receptor antagonists. Historically, other medications were used in the management of SIADH. However, these are non-preferred due to side effects, and these include lithium and dimecycline. Urea supplementation can be considered in patients with refractory or chronic SIADH, non-responsive to fluid restriction. Urea increases excretion of electrolyte-free water by inducing osmotic diuresis. The dose is 0.1 grams per kilo per day, divided into 4 doses, with a max of 2 grams per kilo per day. The adult dosing recommendation is 15 to 30 grams daily, divided into 1 to 2 doses, with a max of 60 grams per day. Urea is available as 15-gram packets of powder for oral solution that can be mixed into 3 to 4 ounces of water or juice. The adverse effects include hypernatremia and stomach discomfort. Evidence in adults suggests similar efficacy and tolerance compared to Vaptans. However, there is limited evidence in pediatrics. Vasopressin receptor antagonists, or Vaptans, can be considered in patients with refractory or chronic SIADH. Vaptans work via inhibition of vasopressin receptors, resulting in diuresis and water excretion. Conivaptan is a nonspecific agent binding to both V1 and V2 and is only available IV. Tolvaptan is specific for the V2 receptor and is available as PO tablets. The major side effects of these medications is increased thirst and dry mouth. These can be troublesome in the outpatient setting due to frequent and urgent need to urinate and constantly drinking water to replace the high urine output. The dose for pediatrics has not been well established and is based off case reports. Conivaptan dosing can be considered as a 0.2 milligram per kilogram load with a max of 20 milligrams, followed by an infusion of 0.2 to 0.6 milligrams per kilogram per day, or a max of 20 to 40 milligrams per day. Tolvaptan can be dosed between 0.1 and 0.8 milligrams per kilogram by mouth daily. It's recommended to likely start on the lower end of this dosing regimen and adjust as needed. Both Conivaptan and Tolvaptan have demonstrated efficacy in adults. However, there is limited evidence in pediatrics. Here I'll present a case report on Conivaptan in a 13-year-old male with metastatic anaplastic large cell lymphoma that developed hyponatremia with a sodium of 121 milliequivalents per liter due to SIADH. Fluid restriction was inappropriate due to the aggressive hydration needed for his chemotherapy induction to prevent tumor lysis syndrome. Conivaptan was selected for this patient due to these concerns of fluid restriction. The dose was 0.2 milligrams per kilogram, which came to 10 milligrams as an IV load over 30 minutes, followed by 0.2 milligrams per kilogram per day, which was 10 milligrams per day, as a continuous infusion. There was minimal change in his serum sodium 6 hours after initiation, so his dose was increased to 0.6 milligrams per kilogram per day, or 30 milligrams daily. 24 hours after infusion initiation, his serum sodium was 129 milliequivalents per liter. His dose was gradually decreased and discontinued over a 4-day period based on serum sodium measurements. This patient developed increased thirst and dry mouth. And here I'll present 2 case reports on tolvaptan in pediatric patients. The first is a 16-year-old female with idiopathic SIADH refractory to fluid restriction. The patient was initiated on tolvaptan 0.28 milligrams per kilogram or 15 milligrams by mouth for 1 day, followed by 0.14 milligrams per kilogram or 7.5 milligrams by mouth every other day. She was initially treated for 14 days, however had a relapse after 4 months, requiring an additional 10-day treatment course 4 months later. This patient had normalization of her serum sodium 48 hours after initiation, and as you can see, only required a short treatment course both times. There were 2 infants with SIADH that was developed within the first month of life. One patient was initially managed with PO sodium chloride supplementation, however this led to hypertension and requiring 4 antihypertensives. These patients were started on doses between 0.1 and 0.6 milligrams per kilogram, which came out to 3.75 milligrams by mouth using crushed tablets mixed in water. The duration of treatment for these patients was 2 to 4 months, and they developed normalization of serum sodium within 24 hours of initiation. As you can see, the dosing for our smaller infants may be more troublesome using tolvaptan, just because the tablet sizes available are 15 milligrams and 30 milligrams, and we can only split a tablet so many ways. Hypervolemic hypotonic hyponatremia can occur in patients when the kidneys cannot excrete water efficiently, leading to volume overload, which can occur in patients with heart failure, cirrhosis, nephrotic syndrome, and renal failure. The management for these patients is fluid restriction, plus or minus diuretic use or dialysis, as well as treatment of the underlying condition when possible. Now let's shift gears from hyponatremia to hypernatremia, with a serum sodium of greater than 150 milliequivalents per liter. Hypernatremia may be due to net water loss, whether it's increased loss or decreased intake, or net sodium gain. Water loss can be pure water loss, hypotonic fluid loss, which involves the loss of bodily fluids with a sodium concentration that is less than that of the serum sodium, or decreased intake. There's an increased risk in those with impaired thirst mechanism or restricted access to water, including those with altered mental status, those that are intubated, are infants, and are older adults. The true incidence of hypernatremia is unknown and again likely underreported. In exclusively breastfed neonates less than 2 weeks of age, they may experience excessive water loss, but this only accounts for 0.4% of cases. Once patients are greater than 2 weeks of age, the most common cause is gastroenteritis with high GI loss. Similarly to hyponatremia, when assessing a patient with hypernatremia, we must also assess their volume status. In patients with hypovolemic hypernatremia, this can be seen in patients with body fluid losses, like burns and excessive sweating, diuretic use, GI losses including vomiting and diarrhea, heat injuries, and osmotic diuresis. Patients that are euvolemic and hypernatremic may have central diabetes insipidus or nephrogenic diabetes insipidus if their urine osmolality is low, or they may have hypernatremia secondary to fever or mechanical ventilation. In patients that are hypervolemic and hypernatremic, it's most likely due to recent administration of enteral feeding or sodium-containing IV products, as well as a history of hypertension or hypokalemia could signify primary hyperaldosteronism. The 2 disease states that we're going to focus on are going to be central and nephrogenic DI. To briefly review hypernatremia management, we first want to identify and treat the underlying cause when possible. We also want to correct the free water deficit, which determines the volume status, and we can calculate the free water deficit. This is reviewed in the Fluids and Electrolytes PPA clinical competency session. Rapid overcorrection of hypernatremia can also result in cerebral edema, similarly to hyponatremia. We have a correction rate goal of 8 to 10 milliequivalents per liter in a 24-hour period. Patients that have a rapid onset of hypernatremia can be corrected quicker, again secondary to that cerebral adaptation not yet occurring. In patients with chronic hypernatremia, meaning their sodium has been greater than 150 milliequivalents per liter for 24 hours, or in patients that have severe hypernatremia greater than 160, we should avoid decreasing our sodium by more than 0.5 milliequivalents per liter per hour, which is 10 to 12 milliequivalents per day. Now let's dive into diabetes insipidus. Diabetes insipidus is a syndrome characterized by the inability to concentrate urine secondary to antidiuretic hormone deficiency or resistance, resulting in polyuria and polydipsia. DI is diagnosed by the presence of high plasma osmolality and low urine osmolality, which can be tested for using a water deprivation test. The incidence of DI is 1 in 25,000. Central DI occurs due to a lack of production or secretion of ADH from the posterior pituitary gland and accounts for more than 90% of cases. Central DI can be idiopathic, whether it's from congenital causes such as septo-optic dysplasia, pituitary hypoplasia, holoprosencephaly, or genetic mutations, as well as acquired conditions. It also can be secondary to damage to the pituitary gland by tumors, infection, or trauma, as well as medication-induced. Nephrogenic DI is where there's no impairment in the synthesis or release of ADH from the pituitary. However, the kidney is unable to respond to the ADH and remove water from the urine, which results in an inappropriately dilute urine and hypernatremia. Certain genetic predispositions, electrolyte disturbances, and some medications may lead to nephrogenic DI. Urine osmolality less than plasma osmolality is consistent with diabetes insipidus. The most common signs and symptoms of diabetes insipidus are polyuria and polydipsia. As you can see, polyuria is going to be defined based on that patient's age. In our neonates, urine output greater than 150 milligrams per kilogram per day, which is about 6 mLs per kilo per hour, will be indicative of polyuria. In children less than 2, a urine output between 100 and 110 mLs per kilo per day, or 4 mLs per kilo per hour. And in children greater than 2, a urine output greater than 40 to 50 mLs per kilo per day, or 1.5 to 2 mLs per kilo per hour. Other signs and symptoms due to effects of intracranial neoplasms on the brain structure may occur. These patients can also present with failure to thrive, fatigue, headache, emesis, and visual field deficits. When evaluating for diabetes insipidus, patients will have elevated serum sodium and serum osmolality, as well as decreased urine sodium and urine osmolality. These patients will have high urine output, leading to decreased fluid status, which they often compensate for with increased fluid intake. While the water deprivation test is the gold standard, it is important to consider other causes of hypernatremia prior to performing. In patients with DI, they will often have very dilute urine and low urine-specific gravity. If the patient is hypernatremic and has elevated urine-specific gravity, the hypernatremia is more likely secondary to dehydration, and the water deprivation test should not be performed. However, if the urine-specific gravity is low, then the water deprivation test can be performed to confirm the diagnosis of diabetes insipidus. The water deprivation test requires serial lab evaluations, and DI is confirmed when serum osmolality is greater than 300 milliosms per kilo and the urine osmolality is less than 600 milliosms per kilo. At this time, you would administer a 1 unit per meter squared subcutaneous vasopressin dose to reevaluate urine output and serum osmolality. In patients with central DI, urine output should fall quickly and urine osmolality should increase. However, in patients with nephrogenic DI, urine output, urine osmolality, and serum osmolality will not change. We also will perform basic metabolic panel in these patients. And a normal serum glucose will help to rule out diabetes mellitus. Normal calcium will help to rule out hypercalcemia-induced nephrogenic DI. A normal serum potassium helps to exclude hypokalemia-induced nephrogenic DI, and a normal BUN makes intrinsic renal disease less likely. Let's dive further into central DI. Although central DI is most commonly secondary to idiopathic causes, there are many more common causes in the ICU, including brain tumors, neurosurgery, infections, and trauma. The incidence of central DI after traumatic brain injury in adults varies with the diagnostic criteria used, the time of the exam, and the traumatic brain injury severity, with an incidence between 3 and 26%. The incidence in children with traumatic brain injury is not as well studied. However, a small case series suggests an incidence of 18%. Central DI within the first 2 weeks of any neurologic insult is an ominous sign, with a high mortality rate in both adults and children, between 69 and 85%. The highest central DI associated mortality is in patients with traumatic brain injury, with a subgroup analysis in pediatrics reporting a mortality rate of 84 to 100%. The goal in managing central diabetes insipidus is to decrease urine output by increasing activity of antidiuretic hormone. We can do this by replacing all previous and ongoing fluid losses. We can restore intravascular volume with normal saline boluses. However, caution should be had when going to provide urine output replacement, as this may lead to further increases in urine output due to the inability to not diurese. Vasopressin analogs are going to be the mainstay of treatment in patients with diabetes insipidus. Other treatment options include low solute diet, including low sodium and low protein, as well as thiazide diuretics. Vasopressin, or antidiuretic hormone, is indicated for the initial management of acutely ill patients with central diabetes insipidus. Vasopressin has a shorter half-life than DDAVP, which allows for easier dose titrations for acutely ill patients. However, dosing may be limited due to the adult max to avoid hypoperfusion to internal organs. Continuous IV infusion is typically preferred due to increased evidence and ease of administration compared to IM and sub-Q doses to our pediatric patients. The initial dose for IV infusion is 0.5 milliunits per kilo per hour, which can be titrated by 0.1 to 1 milliunits per kilo per hour every 30 to 60 minutes, depending on your hospital's protocol, to achieve a goal urine output of less than 2 mLs per kilo per hour. Caution should be had because oftentimes hospitals may have different dose rates that they utilize. Be careful to ensure that your dose is appropriate, whether it's in units versus milliunits or minutes versus hours. The typical max reported rate for vasopressin for DI is 10 milliunits per kilo per hour. IM or subcutaneous injections require administration 2 to 4 times daily. The major side effects of vasopressin include hypertension, intestinal cramping, and decreased intestinal blood flow. Desmopressin, or DDAVP, has a longer half-life than vasopressin, so it is often preferred for chronic management of central DI, but this makes it more difficult to adjust the dose in the acute phase. DDAVP is more specific to the V2 receptor than vasopressin, which leads to a lower risk of hypertension. These dosage formulations are not equivalent, and caution must be had when converting a patient from one dosage formulation to another, ensuring to account for absorption differences between oral, intranasal, and subcutaneous. Nasal liquid is available for rhinal tube administration, and there's also an intranasal spray that have very set increments and requires diligence for proper administration, which can be further complicated if the patient has facial anomalies or an upper respiratory tract infection. The smallest oral tablet size is 0.1 milligrams or 100 micrograms, which can be manipulated for some patients but not for all. Once daily dosing has been suggested to work for some patients, however, it may also lead to wide daily fluctuations in serum sodium levels and is not appropriate for everyone. The subcutaneous dosage form, while it has consistent bioavailability and can be dosed in small increments, the parenteral administration is often a barrier for our caregivers. Because of that, the intranasal formulation can be diluted and administered orally or buccally in our infants and smaller children. Oral and intranasal DDAVP work well in children and adolescents with DI, but management in infants that are dependent on fluid for nutrition often presents a challenge. In patients that are less than 2 months of age, the minimum solute concentration of urine is 50 milliosms per liter and the maximum is 700, increasing to 1400 after 2 months of age. Even in infants without diabetes insipidus, many have a urine output of greater than 5 mL per kilo per hour and will not concentrate their urine greater than 150 milliosms per liter due to the large amounts of fluid ingested to meet nutritional needs. The use of DDAVP leads to an increased risk of water intoxication and hyponatremia in this age group. And while vasopressin and DDAVP are the preferred management options for all patients with central diabetes insipidus, thiazide diuretics have an appealing alternative in this young age group due to the risk of water intoxication. While vasopressin and desmopressin are by far the standard of therapy, and are much more effective at reducing excessive urine output and therefore controlling central DI, thiazide diuretics are an alternative option, particularly in young infants. Thiazides decrease distal tubule reabsorption of sodium through inhibition of sodium chloride cotransporter, inducing natriuresis and subsequent volume contraction. This volume contraction leads to increased water and sodium reabsorption in the proximal tubule, decreasing water delivery to the ascending loop of Henle, where the filtrate is diluted. The antidiuretic effect is more pronounced with a low solute diet, which can be achieved using breast milk or a low solute formula. There are no studies comparing hydrochlorothiazide and chlorothiazide in the management of diabetes insipidus, and the medication choice is likely secondary to what's available, what's covered by insurance, and what the provider prefers. Hypokalemia is the most common side effect reported in patients on thiazides for central DI. However, this can be managed with potassium supplementation or the addition of a potassium-sparing diuretic such as amiloride, which blocks epithelial sodium channels in the distal convoluted tubule, inhibiting sodium reabsorption from the lumen and downregulating sodium-potassium ATPase, leading to increased resorption of potassium. And now let's shift gears into nephrogenic DI. Nephrogenic DI is a syndrome characterized by antidiuretic hormone resistance by the kidneys, leading to an inability to concentrate urine, resulting in polyuria and polydipsia, despite normal or even elevated plasma ADH concentrations. Hereditary or congenital NDI is rare and has an estimated incidence of less than 10 cases per 1 million. The most common form of inheritance is X-linked, accounting for 90% of cases, which leads to a mutation in the vasopressin 2 receptor. Autosomal recessive inheritance occurs in 10% of congenital cases, leading to mutations in the gene coding for water channel aquaporin 2. Acquired NDI is more common in adults than pediatrics and may be due to disorders such as amyloidosis, Fanconi syndrome, renal tubular acidosis, sickle cell, and Sjogren syndrome, as well as electrolyte disturbances including hypokalemia and hypercalcemia, kidney disease, and certain medications such as lithium. It's important to consider the symptoms of the patient and the diagnostic tests, including water deprivation tests and the baseline plasma copeptin measurement, which is a stable surrogate marker of AVP release. Many medications can lead to nephrogenic DI, including antimicrobials such as dimecycline, didanosine, foscarnet, cidofovir, and amphotericin. Our chemotherapeutic agents, including platinum compounds, ifosfamide, cyclophosphamide, and vinca alkaloids, psychiatric medications such as lithium, and other miscellaneous medications, including sulfonylureas and colchicine. The management of nephrogenic DI is challenging, with treatment only managing symptoms. The goals of management are to reduce polyuria and polydipsia. Initial treatment of nephrogenic DI with a thiazide and a low solute diet decreased urine output by as much as 70%. Further urine output reduction can be achieved with protein restriction. However, this often results in poor growth and poor compliance. It's important to ensure proper hydration in these patients and avoid dehydration when at all possible. However, this can be difficult to ensure appropriate water intake in young infants and toddlers during times of inadequate water supply, during febrile illness or gastroenteritis, hot weather, episodic losses of free water, or in the case of surgery. Hydrochlorothiazide in combination with amiloride is recommended to decrease the side effects of hypokalemia seen with hydrochlorothiazide. A recent large cohort study confirmed thiazides and potassium-sparing agents are most commonly used, followed by the combination of these two products, followed by a thiazide plus a potassium-sparing agent plus an NSAID, or a thiazide plus an NSAID. Constipation can also occur in these patients, so it's important to ensure regular intake of laxatives. Vasopressin or desmopressin are not appropriate treatment options for patients with nephrogenic DI because this disease state is not due to a lack of antidiuretic hormone, which is seen in central DI, but a resistance to the antidiuretic hormone. Providing additional antidiuretic hormone in the form of vasopressin or DDAVP will not overcome the resistance seen in this disease state. Prostaglandin inhibitors help to increase urinary concentration ability via inhibition of renal prostaglandin synthesis, or an antidiuretic hormone antagonist. Indomethacin is the most commonly reported prostaglandin inhibitor used in nephrogenic DI. The dose reported is 0.75 to 2 milligrams per kilogram per day, divided in 3 doses. However, indomethacin has significant side effects, including abdominal pain, increased potassium, and GI bleed. These side effects may be controlled if taken with food or a PPI. When indomethacin is added to a thiazide diuretic, there's enhanced proximal tubule water reabsorption, leading to increased urine output reduction 25 to 50% further than thiazides alone. Indomethacin may be superior to ibuprofen, however, ibuprofen is more readily available. This slide was created for you all as a general review of each of the disease states that we cover and what is occurring in each disease state and what the typical management would be. Let's review our key concepts. Sodium and water excretion and reabsorption are regulated in the kidneys by arginine vasopressin, or antidiuretic hormone, angiotensin II, and aldosterone. Cerebral salt wasting is a hypovolemic, hypotonic, hyponatremic disorder due to increased renal excretion of sodium in patients with CNS pathologies and requires correction of the hypovolemia followed by sodium replacement with or without the addition of fludrocortisone. SIADH is a euvolemic, hypotonic, hyponatremic disorder due to inappropriate secretion of antidiuretic hormone resulting in free water retention. Diabetes insipidus is a euvolemic, hypernatremic disorder due to ADH deficiency or resistance, resulting in excessive excretion of free water. Let's dive into our assessment questions. Question 1. Plasma osmolality is maintained by strict regulation of the antidiuretic hormone system and thirst. How is ADH secretion affected if plasma osmolality increases? Antidiuretic hormone secretion is increased and water is reabsorbed by the kidneys if plasma osmolality increases. AT is a 4-year-old female involved in an MVC resulting in severe traumatic brain injury. On day 4 of admission, AT's sodium levels begin to decline despite no major changes in medications affecting sodium. Her urine output remains stable at 1.7 mL per kilo per hour. However, she has some signs and symptoms of hypovolemia. Urine and serum labs are serum sodium 128 milliequivalents per liter, serum osmolality 275 milliosms per kilo, urine sodium 55 milliequivalents per liter, urine sodium 325 milliosms per kilo. What sodium disorder does AT appear to have? AT has cerebral salt wasting. Based on your diagnosis, what treatment regimen would be appropriate for AT? For cerebral salt wasting, isotonic saline infusion to achieve euvolemia plus fludrocortisone would be the only appropriate choice. You could consider sodium supplementation either IV or intraorally, given the acute presentation of cerebral salt wasting. However, based on your answered choices, the only option with sodium chloride supplementation would be fluid restriction, which would be inappropriate in a patient with cerebral salt wasting with signs and symptoms of hypovolemia. DG is a 13-year-old male status post neurosurgical intervention for removal of an intracranial mass. 10 days after removal of the tumor, DG is experiencing new onset polyuria with a urine output of 2.8 mL per kilo per hour in polydipsia, as well as persistently elevated serum sodium 154 to 161 milliequivalents per liter over the past 36 hours. Upon further review, his labs demonstrate a serum osmolality of 340, a urine sodium of 20, urine osmolality of 260. What sodium disorder is DG exhibiting? DG is experiencing diabetes insipidus. Based on your diagnosis, what treatment regimen would be appropriate for DG? Based on your answer choices, DDAVP would be the most appropriate treatment management for DG. Thank you for making it to the end of this module. These next 2 slides contain the references I used for creation of this presentation. Thank you for attending, and I hope that you learned something from this presentation.